Welcome back to ER Mentorship Hub. Today, we're tackling a serious condition known as necrotizing external otitis, or malignant otitis externa. This is more than just an ear infection. It's a potentially life-threatening condition that demands our attention. We'll start with a case study of a patient, Joe, and then foundations, clinical features, diagnostics, and management of NEO. Joe, a 65-year-old Samoan gentleman. He's been a diabetic for over 15 years, managing his condition with medication and diet. Recently, he's faced a new challenge. Joe came to us with discharge from his right ear. It started as a minor discomfort a few months ago, but gradually worsened. Initially, he thought it was just an ordinary ear infection. He tried over-the-counter eardrops and even some home remedies suggested by friends, but nothing seemed to work. The pain here that it started affecting his sleep and daily activities. What makes Joe's case particularly concerning is his history of diabetes. We know that diabetes can weaken the immune system, making infections harder to fight off and more likely to become serious. This condition puts Joe at a higher risk for more aggressive infections, external otitis. When Joe finally sought medical help, he described the pain as sharp and constant, radiating to his jaw and neck. The discharge from his ear was initially clear, but became purulent over time. He also mentioned feeling a bit unsteady on his feet, which was a red flag for potential complications. Joe's case underscores the importance of early intervention, especially in patients with underlying conditions like diabetes. It also highlights the need for healthcare professionals to look beyond common ailments and consider more serious conditions when presented with persistent symptoms. Necrotizing external otitis, NEO, also known as malignant otitis externa, isn't your typical ear infection. It's a severe, invasive infection that affects the external auditory canal and can even spread to the skull base. This condition is particularly aggressive and can lead to serious complications if not promptly managed. Who is at risk? While anyone can develop NEO, it predominantly affects certain demographics. It's most commonly seen in the elderly, as the aging process can reduce the body's ability to fight off infections. However, the risk is significantly higher in individuals with compromised immune. This includes patients undergoing chemotherapy, those with HIV/AIDS, or anyone on long-term steroid therapy. One of the most significant risk factors for NEO is diabetes mellitus. High blood sugar levels over a prolonged period can impair the immune system and damage blood vessels, making it harder for infections. In diabetics, even a minor ear infection can escalate into NEO if not carefully monitored and treated. The most common pathogen associated with NEO is Pseudomonas aeruginosa. This bacterium is particularly notorious for its resistance to many antibiotics, NEO challenging to treat. Pseudomonas thrives in moist environments, which is why it often targets the ear canal. While Pseudomonas is the primary offender, other bacteria can also cause NEO. Staphylococcus aureus, including its methicillin-resistant strains, MRSA, can be responsible. In less common pathogens like Proteus mirabilis or even fungal organisms like Aspergillus may be involved, especially in patients with a more complicated clinical history or those who don't respond to standard treatments. Identifying the correct pathogen is crucial for effective treatment. For this reason, large samples for culture and sensitivity testing is an important step in the management of NEO. This helps in tailoring the antibiotic therapy to the specific organism causing the infection. Symptoms. Persistent otorrhea. NEO typically presents with a discharge, known as otorrhea. This discharge can vary from clear to purulent and is often resistant to conventional treatments. It's not just the persistence, but also the nature of the discharge that raises a red flag. Severe otalgia. Patients experience intense ear pain, or otalgia, which is throbbing or stabbing. This pain can be debilitating, affecting sleep and daily activities. Unlike typical ear infections, the pain in NEO tends to persist and worsen over time. Headaches and other symptoms. Neo can also cause headaches, which might be due to the infections in areas. Some patients report a feeling of fullness or pressure in the ear, and in advanced cases, there can be hearing loss. Granulation tissue. A key feature in diagnosing Neo is the presence of granulation tissue within the ear canal, particularly at the bone junction. This granulation tissue is indicative of ongoing inflammation and infection, and its presence in this specific area is a distinctive sign of Neo. Complications. Involvement of cranial nerves. One of the most serious aspects of Neo is its cranial nerves. The facial nerve is most commonly affected, leading to facial paralysis or weakness. This can be alarming for patients and is a sign of the infection's severity and progression. Risk of meningitis. In some cases, the infection can spread beyond the ear and skull, involve the meninges, leading to meningitis. This is a medical emergency and requires immediate intervention. Possibility of brain abscesses. Another severe complication is the formation of brain abscesses. These are pockets of infection within and can be life-threatening. Early detection. The key to managing Neo effectively lies in early recognition of its symptoms and potential complications. Timely intervention can prevent the progression of the disease and reduce the risk of these severe outcomes. Severe otitis externa. This is a more common form of ear infection affecting the external ear canal. Unlike Neo, it typically responds well to topical treatments. It's important to distinguish this from Neo, as severe otitis externa doesn't usually lead to bone involvement or systemic complications. Persistent symptoms, despite treatment or the presence of granulation tissue, should raise suspicion for Neo. Otitis media. Otitis media affects the middle ear and is common in children, but it can occur at any age. It often presents with ear pain, reduced hearing, discharge if the eardrum ruptures. The key to differentiating otitis media from Neo lies in its location, the middle ear, behind the eardrum, and the absence of extensive inflammation spreading to the external ear and beyond. Mastoiditis. Infection of the mastoid bone, just behind the ear. It often stems from unresolved otitis media. While it can present with ear discharge and pain, mastoiditis is typically accompanied by swelling and tenderness over the mastoid bone. Distinguishing it from Neo is crucial, as mastoiditis might require referred pain from other sources. Pain originating from the teeth, sinuses, throat, or temporomandibular joint can sometimes mimic ear pain. A thorough evaluation is necessary to rule out these sources. A careful examination, including an assessment of the oral cavity, temporomandibular joint, can help differentiate these conditions from Neo. Diagnostic testing. There's no single test for Neo. A combination of clinical evaluation, lab tests, and imaging like CT scans or MRI is key for an accurate diagnosis. Management and disposition. Immediate response on suspicion of Neo. Initiation of systemic antibiotics. As soon as there's a suspicion of Neo, prompt initiation of systemic antibiotic therapy is crucial. This is because Neo can progress rapidly and lead to severe complications. In Joe's case, we started him on ciprofloxacin, a fluoroquinolone antibiotic. It's effective against Pseudomonas aeruginosa, the most common pathogen in Neo. The antibiotic penetrates well into the bone, which is essential for treating any potential osteomyelitis. Consultation with consulting an otolaryngologist is vital. They can provide specialized care, including ear canal debridement, which can aid in the treatment and provide samples for culture to guide antibiotic therapy. Interdisciplinary approach. In some cases, an infectious disease specialist will be valuable, especially in patients with complicated medical histories or those not responding to initial treatments. Duration of treatment. Treatment for Neo is prolonged, typically lasting 6 to 8 weeks. This duration is necessary to ensure complete eradication of the infection and to prevent relapse in Neo. Throughout treatment, patients need close monitoring. This includes checking for clinical improvement and any side effects of long-term antibiotic use. Lab tests and follow-up imaging can be used to monitor the response to treatment. Consideration of surgical debridement. In some cases, particularly where there's necrotic tissue or failure to respond to medical management, surgical intervention might be necessary. This can range from minor debridement to more extensive procedures. While extensive surgical treatment in the past, advancements in medical therapy have reduced the need for aggressive surgical approaches in many cases. Long-term follow-up. Even after the completion of treatment, long-term follow-up is essential. Neo has a risk of recurrence, and continued vigilance is necessary to is completely resolved. Neo is a complex condition that requires a keen eye and swift action. Joe's case is a reminder of the importance of thorough evaluation and tailored treatment in the ER. For more insights into critical ER conditions and their management, don't forget to subscribe to ER Mentorship Hub. Your engagement helps us bring valuable medical education to healthcare professionals and students alike.